Thank you all for being here at the Journal Record's second roundtable to discuss the opioid crisis in Oklahoma and how it's being addressed. We had our first discussion this summer, and our goal today is sort of a progress report to find out what's changed on that landscape, what progress has been made in curtailing that epidemic. I'm Ted Struley, editor and associate publisher of the Journal Record, and before I introduce today's panelists, I want to extend our sincere thanks to Bob Howard and Mercedes-Benz of Oklahoma City for making today's discussion possible. Because of that sponsorship, the Journal Record will be able to publish an edited printed transcript of today's conversation in the newspaper, and we'll have that as well as the complete transcript, full video, and edited video segments available at journalrecord.com. So thank you again, Mr. Howard and Mercedes-Benz of Oklahoma City, for making this important information available throughout Oklahoma. We'd also like to thank our host and partner, KOSU, for allowing us to use their beautiful broadcast facility here on Film Row. So let's get started. Today joining us are Jessica Hawkins, the Director of Prevention Services for the Oklahoma Department of Mental Health and Substance Abuse Services. Julia Jernigan is the Executive Director of the Oklahoma Behavioral Health Association. Mike Hunter is the Attorney General for the state of Oklahoma. And Dr. Jason Beeman is the Chairman of the Department of Psychiatry and Behavioral Science at Oklahoma State University's Center for Health Sciences. And our format today, we do have some formal questions and answers, but I've also asked the panelists this time to feel free to be conversational and talk amongst themselves on this topic, since we have such strong expertise in the room. So just to get things started, General Hunter, I'm going to start with you and ask for kind of a progress report. As many of us in here today already know, Attorney General Hunter stood up really to the Oklahoma Commission on Opioid Abuse. They've been meeting over the past several months to take a comprehensive look at the state's opioid epidemic and come up with a set of recommendations for the legislature and the governor to combat this deadly epidemic. So at our last forum, the commission had not yet met, as I recall. General Hunter, could you give us an update on how those meetings are going, and then go on and tell us a little bit about how, through those meetings, what kind of ideas for legislation we're maybe going to see coming up?
Well, I think, Ted, we're making good progress. The commission is populated by almost everyone who has a stake in dealing with the opioid abuse epidemic. We have prescribers, we have people from the state in terms of healthcare interests. We have two very fine legislators, we have law enforcement, and then we have the business community represented. So the goal is, teasing from the various presentations that we've had, to come up with best practices for what Oklahoma can do to be more effective in abating the epidemic, overdoses and overdose deaths. So we've come up with a range of things. I think a consensus is developing. But the important thing is to come out with a consensus. We've got to have prescribers on the same page with law enforcement. We've got to have people who deal as a profession with recovery and rehabilitation. We've got to have their input and their imprimatur on how we and what we recommend. So I'm very confident. I don't want to forecast what we're going to be reporting, because that would be inconsistent with the team approach that we've adopted. But we're having one more meeting later this month, and we hope at that meeting to agree on what we're going to be proposing, and then we've got to develop black letter law, and we've got very good legislative representation. Tim Downing from the House and A.J. Griffin from the Senate are both stars, and they're going to be hopefully the authors of the legislation that we propose.
It strikes me that having that particular combination of people, the different areas that are represented by those people in those meetings, could easily kind of bleed over into wider collaboration among various stakeholders. And in talking to each of you earlier, I heard collaboration come up from at least 3 of the 4 of you in our conversation. So I think, Julia, we'll just start with you down at that end, and maybe each of you can talk a little bit about what kind of collaboration we might be looking for between what kinds of agencies, government, private sector, nonprofits, whoever might be involved, certainly the prescriber community. How do all those elements come together, and are they coming together in any more noticeable way now than they were when we were talking about this summer?
Yeah, and I definitely want to commend Attorney General Hunter on bringing everyone to the table, because that's what's really going to solve this problem. You know, when we move out of those silos and start to realize who has the expertise in the room and who can really push forward legislation or new policy to better ensure that not only our citizens but our state gets out of this crisis mode. And so I think you're going to see a wide range. I think the business community is really important. Like you said, law enforcement, district attorneys, our community in particular on the treatment side, we're really excited to see this collaboration, because for a long time we were the only ones saying, right, there's a problem. And now other people are coming to the table and saying, what can we do? So having prescribers and everybody else in the room, I think, only moves the policy forward, and then which moves our state forward out of this crisis.
Yeah, I've really seen the medical community step up in really significant ways recently. The Department of Mental Health and Substance Abuse Services, for example, has been working with the State Medical Association that just hosted a very large continuing medical education course over 2 days, training about 300 physicians in opioid prescribing guidelines and pain management, and also medication-assisted treatment. That's impressive. That's a lot of people being reached about the need for appropriate prescribing. And in that same vein, we know that one of the best interventions that we can implement to reverse this problem is much more cautious prescribing. And to that end, our agency has also been working with the University of Oklahoma Health Science Center to develop a program that will go into primary care practices and actually teach them the guidelines firsthand. So it's one thing to go to a training or to read a set of clinical practices. It's much more difficult to implement those when you go back to practice, and the busy pace of having a busy practice can really be overwhelming. And so the University of Oklahoma and our agency through this project will be able to embed some peer educators and what we call academic detailers, other doctors, to go in and work with those practices to really transform their offices toward using the pain management guidelines. We're excited about that. We have over a dozen practices already signed up, and in the next year we'll be in about 20 practices throughout the state doing that program. Those are just 2 examples, but we've seen a lot of collaboration, more than I've ever experienced on any other subject matter, and I think that's really what it's going to take to reverse this trend.
Well, I think collaboration is the name of the game for OSU Center for Health Sciences. We have really dramatically increased our addiction services in the last 12 months, and it's been mostly through collaborative efforts. First and foremost, I think that we're always a good partner with the Oklahoma Department of Mental Health and Substance Abuse Services, and are looking for a lot of different ways to collaborate with them. And we've had some initial meetings, and we'll have some final meetings going for hopefully a formal collaboration specifically designated on the opioid epidemic sometime in the next 1 to 3 months. And then we have in Tulsa partnered with the local state-funded treatment facility 12 and 12, where now OSU is the medical providers in that facility. And with that collaboration, we are opening a freestanding addiction medicine clinic that will hopefully be open in the next 90 to 120 days. And that will be a collaboration with probably one of the nation's leading experts, leading organizations on the treatment of addiction. So we're trying to bring in, not just utilize Oklahoma resources, but actually bring in the national experts on treating addiction and utilizing those services. We continue to collaborate with our tribal relationships in the Indian nations, and we are looking for, besides our addiction medicine clinic in Tulsa, we're looking to leverage cooperations for a clinic possibly in Enid, and then another one in Tahlequah, specifically designed to treat addiction, really focusing on the opioid epidemic. So we really just keep looking for cooperation and collaboration everywhere we can. One thing I think we don't want to do is have redundant services so that you have some places getting twice as much and some places getting none. So we're trying to identify the places where we can be of help and not create redundant services.
It sounds like there are a lot more entities involved in fighting the epidemic than there were 5 or 6 months ago when we were here, which sounds great. I'm curious though, and Julie, I'm going to come back down to your end and we'll do this again, but who's missing from the table? Who's not involved in this yet who maybe should be?
I would probably like to see, we do have some legislators that are involved and interested, but I would like to see even more legislative involvement, just so that it's not just the two of them carrying this the entire weight. And so just getting some more of those folks interested and wanting to jump on board and help see this through, I think would be really wonderful as well.
Anybody else? Other panelists? Anybody missing from the table that maybe the state should be trying to attract to the table to get involved in this conversation?
I would say that everywhere I go, I see an open door and an open mind. So specifically related to the opioid epidemic, I think it's gotten to the point now where everybody is interested in realizing that it's a problem. And I haven't really run into any roadblocks and forming relationships or anything like that. I think the crisis is to the point now where everybody's heard of it and everybody acknowledges that it's a problem.
Good. Dr. Beeman, as long as we're down at this end of the table, could you talk a little about how you've seen the epidemic change since the last time we met in this room?
Yeah, I think it's been a short amount of time, but we have seen some noticeable trends. Clinically, I have definitely seen an uptick in heroin, and I think that that's going to be a big problem for the state of Oklahoma. If we are going to target the opioid epidemic from a regulation standpoint, specifically aimed at prescribers, which I think is important to do. And I hope that that's some of the product that comes out of the Opioid Commission is looking at the prescribing patterns and how can we better control the supply, because it is clearly a supply and demand issue. As we divert people from the medical prescription route, the national trend has been then to go on to heroin. People who are addicted to opiates can't necessarily just stop because they don't have a supply. They will try everything in their power to continue that addiction. And that often leads to them being diverted to heroin. So if we're going to do the regulation aspects, we have to be prepared and have to have treatment available for those individuals so that we can catch them before they divert to heroin, and we can catch them into the safety net and provide them treatment and get them back on the course of their life. So heroin uptick has been one trend, and that's going to come with an increase in overdose deaths because it's easier to overdose on heroin than it is for the prescription pills. And then I think we would agree that we've seen an uptick, and I think at this point it's small, but an uptick in fentanyl. And fentanyl is a synthetic opioid that very unforgiving to taking an overdose in. So I think we'll continue to see an increase in overdose deaths. On the flip side, the good news is I think we've seen a tremendous uptick in awareness and collaboration and cooperations just in the last 6 months. And I've seen a lot of other of the initiatives that we've had, including the department's effort on getting naloxone out to prescribers and getting them to use it. I think I've seen a lot more of that and a lot more people aware of that in the last 6 months. So I think that the public health campaign, including initiatives like this, have made a dent.
Could you elaborate a little bit on naloxone and how that's used?
Yeah, opioids block the receptors that tell us to breathe. And naloxone is a medication that can go and push the opioid off of that receptor for a short amount of time. So you should very much look at it like the epinephrine pen, that it's something that you have to carry around for the what-if situations. And there are a lot of times when you think that you won't need it, when you will. And if we can get individuals who are at risk for overdosing to have access to this medication, then they can use it and prevent the overdose. And in the meantime, we would like to see them get into some sort of clinical situation like an emergency room, an ambulance, something like that, because the medication does not always work as long as the pain pill does. But it provides us a temporary reprieve to stop individuals from dying.
You mentioned the public health aspect of this and ways to address that in the clinic. Certainly at my newspaper, we have written extensively about state funding this year and the budget problems and the resources that have been curtailed for a lot of state agencies and a lot of pieces of the public sector. Each of you has some interaction with that in one way or another. So maybe, Julia, we could start with you and just talk a little bit about how resources to fight this epidemic have been affected positively or negatively. Is the money flowing or the resources available? Are they coming from the state? Are they coming from elsewhere? Are we coming up short on the money front to fight this?
And there's been a few resources that have came from the federal level through a grant, and I'll let Jessica probably talk a little bit more about that. But, you know, and we've seen that come down to the state level. But at the state level, we definitely could always use more resources, especially in this area, not only for the Department of Mental Health, but also looking at OU and OSU that is trying to partner with us on this. And so not only just looking at resources there, but in other agencies that we're collaborating with. So I would say that there's always room for resources, of course, at our state level and at our federal level, but there has been a federal grant that has came down to the states specifically for opioid addiction.
So for us, you know, state opportunities to apply for federal funds has really been the backbone of our work thus far around opioids. And we've been incredibly competitive and have been able to bring many of those resources to the state, mostly because of the scope of the problem here in Oklahoma. But yet we have to compete with all the other states and territories and sometimes tribes for those funds. So they can be quite tenuous, and they're typically hard to sustain because they're short term. And it can be difficult to get evidence-based interventions going and show outcomes and really intervene appropriately quickly with those federal grants. So even though we've had them, we're very appreciative of them. They've allowed us to do some things such as our naloxone program that's been talked about thus far, and also increasing medication-assisted treatment. They're not going to be here long, and we do have to find sustainable ways to continue to fund prevention and treatment services in our state over the long term. And really, if we're going to resolve this problem and also address our overall risk for substance abuse in Oklahoma, we have to be focusing a whole lot more on prevention. And by doing that, it means we have to have a long-term strategy. We have to figure out the factors that are really driving these conditions here in Oklahoma, not just the opioid problem, but other conditions that are related to that, and appropriately fund those services. I believe we can do that. And thankfully, our budget shortfall has gotten smaller over these last few months, but we have funding right now as an agency to get us through about spring. And so we really do need to address the continued shortfall in that state budget in order to sustain not only these services, but to build an investment in Oklahoma into the future.
Well, I would say that when we look at this epidemic, really the largest funding source and the people who should be in charge of funding it, I think, would be the Department of Mental Health and Substance Abuse Services. And when you think about the scope of the problem, this is like over the last 10 years, this problem didn't really exist. And so now they're in the middle of the biggest epidemic to hit the state of Oklahoma. They should have had an increase in funding accordingly, because this isn't something that they were necessarily planning on 10 years ago. And if we just had an outbreak of the bubonic plague, you would see increased resources going towards that. And the department was tasked with treating this epidemic, but weren't giving the full resources. Right now, they're just trying to stay equal with all the budget cuts that are possible in the state budget crisis. But I think really, if we are calling this an epidemic. In medicine, it meets all the parameters of an epidemic. Oklahoma is one of the hot spots in the country. The Department of Mental Health and Substance Abuse Services should see an increase in funding to treat the epidemic. I think that they are probably one of the best prepared agencies to distribute the money and make sure it gets used in an evidence-based manner, doesn't get diverted off and whatnot. We are cooperating with them, collaborating with them on a lot of the federal money, which they've been very aggressive in going after every federal dollar. So we talk a lot about the state budget, but I think it's important to note that ODMH SAS has received a lot of federal dollars to fight this epidemic, and a lot of those are matching. So if they lose money from their budget, it's not necessarily a one-to-one loss, because every dollar that they lose has the potential of losing $2 or $3 in the federal matching funds. So it could have widespread changes. With that being said, I think everybody in the room would agree that we do need a state budget, so at least we know what resources we have to fight this and how we can allocate those. OSU is at the center of higher education. My department is mental health, and then we are healthcare in general, so we're kind of always the three areas that are on the chopping block, and so we're just waiting to see what our funding is. But I think that there's a large philanthropic interest in fighting this epidemic, and they've been very involved in providing resources when they can. And so I think we just have to put money together from federal, state, and local dollars to do the best we can to get a hold of this epidemic.
So we're hopeful with respect to the litigation that we filed, and as has been reported, we were successful last week in court in convincing a judge to overrule the drug manufacturer's motion to dismiss. And so we'll be the first state who has litigation in which a court has allowed discovery to begin with regard to what we believe we're going to uncover as a system, a practice, multi-decade in nature, in which prescribers have been defrauded and the addictive qualities of opioids misrepresented. So our goal is a judgment that will allow the state to recoup what we believe to be billions of dollars in healthcare costs, law enforcement costs, corrections expenses. And my goal would be to dedicate that money to getting those people who have suffered as a result of all this better. So the outcome of that lawsuit isn't imminent. We're probably looking at a couple of years and a trial, but we feel real good about where we're going to end up there. In the near term, I think that the Commission is going to be looking at proposals that will identify ways for the legislature to dedicate funding to treatment and rehabilitation. And we've got to get people better, and that's got to be part of the focus of what we take to the legislature. It's easy to say we need more money. It's another thing to actually, in a thoughtful, deliberative way, identify ways for the legislature to go out and get that money without it really having an impact on taxpayers. So I was, like many of us, I was hopeful the legislature would conclude their business in an orderly way. That will, I'm an optimist. That will hopefully happen in the next several weeks, and we can get focused on establishing priorities. But funding's important. A lot of effort in the state in the criminal justice reform space. Being smart on crime. Being smart on crime means you've got to be smart on funding treatment and rehabilitation. Prime example is we've never funded drug courts to the extent that we need to. So those are all areas that the legislature needs to identify and establish as a priority, and part of what we on the Commission are going to be focused on doing is helping them with regard to that.
If I can, let me stay on the litigation for just a minute. Maybe you can, for those who are going to read this or view this who haven't read all the coverage from Judge Balkman's decision last week, talk a little bit about what that argument was. There were several hours of arguments on that motion to dismiss that largely ruled in the state's favor. Maybe talk about a little what was at stake there, what the arguments were, and what happens next in that lawsuit.
Happy to. The premise of the defendant's motion to dismiss essentially occurred in two areas. One was preemption. The FDA had approved these drugs. The FDA had approved labeling. Therefore, the defendants argued we shouldn't be responsible for the fact that people aren't paying attention to labeling, that prescribers are making decisions about who gets these drugs, and at the end of the day, it's their responsibility. The FDA does not approve marketing materials for these drugs. It didn't approve commercials. It didn't approve the years of brainwashing that occurred, the pseudoscience that was brought to practitioners. So the judge was unmoved by the preemption argument. Moreover, he was unmoved by the idea that prescribers have the responsibility for all of this. Well, the effort that went on to, I choose this term not to be hyperbolic, but the effort that went on to brainwash prescribers about how these drugs were going to affect patients and that the time release element of it was going to preclude addiction. I mean, that was the education, if you will, that prescribers brought to decision making around their patients. And so for the drug companies to say, hey, it's not our fault, these prescribers made these decisions, well, those decisions were based on the education process that manufacturers brought to prescribers over the last couple of decades. So the judge was unmoved by their arguments. We lost a very small claim that actually only had a 1-year statute of limitations, a consumer protection claim. So we were not at all disappointed by that as a very small part of our theory of recovery. We're going back to court on January 11th to establish scheduling that will allow us to begin recovery, will allow us to begin discovery in the lawsuit.
And I think I can speak a little bit to the brainwashing aspect is that not only was it based on some pretty faulty scientific studies, we would have never have used diabetes medicines or hypertension medicines based on the studies that they based their argument on. But at the same time, there was this huge push from the periphery to start treating pain and treating it much more aggressively, the development of the Wong-Baker scale of happy faces for how your pain is, and that doctors were told through different regulations and guidelines that based on a patient's own perception of their happy face, so if you were happy, then it was a 1 to 2. If you were really in pain, then it was an 8 to 10. And based on doctors' or a patient's perception of their own pain, doctors were required, or it was strongly suggested that it was unethical not to do so, that they had to give an opioid pain medication. And so we started to treat pain like we did blood pressure. We want your blood pressure to be at this number. If it's not, we give you blood pressure medication. We want your pain to be at this face level, and if it's not, then we have to give you an opioid pain medication. And these have-tos were given to us by national guidelines through pain societies and specialty organizations, but they also came down through different government regulations, and the language in the regulation very much mirrored what was coming out of the pain societies that had close collaboration with the opioid manufacturers. So you can kind of clearly connect the dots to how we got there. So doctors were being told that if you're not treating pain in this manner, you're being unethical, you could possibly be committing malpractice, and you could lose funding, you could not get reimbursed because you're not in compliance with regulation efforts. So it was really a multi-pronged attack on prescribers to get them to do that. And when you see all of those efforts coming together, you start to see opioid prescriptions dramatically increase. And I definitely believe in the ethical treatment of pain, and patients do have a right to comprehensive pain management. But when you look at the numbers, that 80% of the opioids prescribed in the world come from the United States, you know that something different is going on here. Are we hurting more than other countries? I don't think so. I think that there's an inherent problem within the prescriptions. And I think that that's what the Attorney General is going after.
All right, follow-up question on how we're prescribing opioids, or how we have been recently. Are we giving more medication to each person, or are we giving more people opioids, or is it a combination of the two?
I would definitely say a combination of the two. That a lot more patients, and it's not necessarily now. I think word is getting out, and some of the prescriptions numbers are declining. Oklahoma has always been at the forefront of the amount of prescriptions given. So when you compare us to other states, we prescribe more historically. But around 2000, you saw a dramatic increase in not only the number of prescriptions that were being written, but also in the morphine equivalent dosing of how much of those prescriptions we were giving. So a lot more higher doses to a lot more people.
General Hunter, can I ask you to maybe draw a parallel TSET from the tobacco settlement, which was a huge amount of money and certainly not an identical kind of litigation, but I think you'd agree there are some similarities there. That set up a phenomenal fund that we've been drawing on for years to educate the public and try to decrease smoking in the state. Can you maybe just paint a picture of how your litigation might parallel the tobacco litigation of some years ago?
Well, I think the goals of the two cases are very similar, and that is sometimes companies, sometimes business people do bad things, and they need to be held accountable. So the extent to which tobacco had impacted the health of Oklahomans was something that was the centerpiece of that case. Around the country, it became clear that there needed to be a multi-state solution to what tobacco companies were doing. And that multi-state solution allowed for states to, based on the settlements that each state received, to set up, if they chose to, trust funds and allow the income from the investments of those trust funds to go to both the health issues related to the use of tobacco and smoking abatement. So I think we have a similar goal here. One of the things I would say that's a little bit different is we've got to deal in a fairly immediate way with addiction and with those who are suffering. So my vision is that we'd have some money that's set aside immediately to sort of jumpstart and accelerate our rehabilitation services funded by the state for people. And then the balance of that money would be put in trust and the income invested in treatment and rehabilitation. But we're several years off. Again, I think the comparison's apt. I'm not sure that in the last year before the tobacco litigation was settled, I'm not sure 60,000 people died around the country attributable to tobacco. So the one difference that I would identify is this healthcare challenge is much more profound, much more nightmarish, and having some money immediately in the pipeline to deal with addiction makes sense to me, and then dedicating the rest in a trust fund sort of way, similar to TSET.
Hey, Dr. Rubin, I'm going to ask you to draw a similar parallel that occurred to me just a week or so ago when World AIDS Day was in the news a couple weeks ago, but it seems to me there's maybe also a parallel there where in the mid to late 80s we had an epidemic starting that rose very quickly if you were to draw a line graph. And it took a little while to get attention focused on that and to start finding some ways to deal with it. And once it reached a certain point after a few years, we see a big leveling and drop off that I think you'd agree was a combination of both some medical revelations and a lot of public education on the topic. Do you see a similar track here with opioids? Is there a vast difference in those? I think the similarity is we had a widespread problem resulting in a lot of deaths.
Yeah, and I think there are some comparisons, and there's some areas where you can't compare, and actually there's just a continuation of the HIV epidemic that I can speak of. So the ways that it's very similar is that you have a lot of stigma around it, and that's one of the things that was required for the HIV epidemic, is to break down the stigma of the individuals who were getting infected in order to increase testing, increase treatment, and all of that. We see the same thing with addiction. One of the big differences is that the opioid epidemic, the majority of people that are becoming addicted are coming through that addiction through no fault of their own. And I don't want to blame people for getting HIV, but it is a behavior-driven infection, whereas someone gets addicted to opioids by going to their doctor and doing everything their doctor tells them to do. A high school athlete with a back injury goes and the doctor says, take this medicine for the next 30 to 60 days, and that individual does that and then is now addicted. So there's a big difference there. The two are not necessarily exclusive in that Indiana had a horrible HIV outbreak in the last 3 years, something around 200 plus cases in one county. That's unheard of. That's unprecedented for an HIV infection rate at this day and age, and mimics what we saw in the early 80s. And it was directly related to IV use of opioids. And so if we don't get a hold of this, we're going to have an HIV outbreak epidemic. We're going to have to put into place legislation and other preventative efforts to prevent needles being used again and again that could spread HIV. HIV also comes with hepatitis C, and so the lifelong treatment of that one county in Indiana of individuals with not only addiction but now HIV and also hepatitis C is going to be a very large amount of money. And I think Oklahoma has an opportunity now to get ahead of that curve and to put into place a lot of different treatment efforts and initiatives that can prevent such dramatic costs to the state.
I'll just also mention, too, one area that General Hunter's commission's been looking at, I think, and I'm glad has been, is around data and how we share information and also track this particular epidemic, because central to any sort of public health emergency like HIV/AIDS, you have to have good information. That information has to be shared appropriately. You have to track trends and then allocate resources in the right places. Oklahoma had at least one county, for example, that the CDC predicted would have a similar outbreak as the one that Dr. Beeman just mentioned, because of our data indicators point to at least that one county as being at very high risk or very vulnerable, if you will, to a public health emergency like that. And so similarly, it's going to take not just prevention, intervention, and treatment, but we also, underlying all that, is a really good surveillance system to be able to identify what's happening. For example, in our states, we do have, in our state, there's some limits around when we learn about when somebody dies of an overdose, when somebody goes to a hospital through the emergency department and is then discharged home. We don't always know about those cases. It makes it hard for us to hotspot or use some of that information to put resources or interventions in place. And so similar to really any other public health epidemic, we have to have all three areas in place: prevention, intervention, and treatments concurrently, and then also have this identification of surveillance and data in order to track what's going on in the state and make predictions too about what could happen so that we could prevent them in the first place.
And I would very much echo that you know, at OSU Center for Health Sciences, part of our effort to combat this epidemic is robust research, and we're putting a lot of research resources to this. And if we had access to data that now kind of exists in silos, because a lot of people are being protective of different behaviors, but if we had access to that in a de-identified way, we could work with the Department of Mental Health, but provide robust prevention efforts, treatment efforts, education efforts for those hotspots. But identifying the hotspots can take years, and by the time we identify it, it's already migrated and moved. And, with the data that's already available, we could work with local law enforcement and local treatment facilities and really try to hit the hotspots as they pop up. And then I think we would show much increased outcomes, much improved outcomes.
We've talked a lot about the basis for the litigation has a lot to do with marketing opioids and spreading a message. It wasn't too long ago that President Trump made a very public pronouncement about opioids being a national epidemic. Julia, maybe you could start us off, but everybody just talk a little bit about how that kind of pronouncement helps, how it helps in a tangible way, or how it helps in perhaps a softer way of just public awareness. Does it make any money flow, or does it just get it on people's radar?
I think it does a little bit of both. It again, back to when you brought up the World AIDS Day, it breaks down that stigma. And so it's getting people, not only the public, but those that are needing the treatment itself, breaking down that stigma, which breaks down the barriers for them to get to treatment. I guess we would all hope that with kind of that proclamation that he said, there would be some funding, not only at the federal level, but going back to, again, is it going to be those private dollars or any kind of other areas that would want to come in and jump in to help with the crisis? And so I guess it would be kind of a two-prong approach. It not only gives a stage for the public to realize what really is going on, but it also hopefully puts in the mind of some of those that might want to come and help financially, both at the federal level or just in the private and state, getting them motivated to do that.
I think there's a lot of hope that in addition to funding, which we've all addressed as being central to addressing this problem, is also certain regulations or rules or laws at the federal level that have been barriers to addressing this problem. And one, for example, that I know Dr. Beeman could speak to is the limit to the number of patients that a physician can see for medication-assisted treatment services. And those are things that really, unless I'm unaware of a method to do that states' hands are really tied. And we have a shortage of physicians in Oklahoma who are waivered to prescribe medication for opioid use disorder. We need a lot more of those services provided, and we have physicians who are ready and willing to take on more patients, but they're limited by a DEA rule, for example. That's one example of many areas where one would hope that the National Declaration of a Public Health Emergency would release some of those levers and really give us some more flexibility at the state level.
I would agree. I think it was definitely helpful that the president came out and announced it. I think by the time he announced it, it was no surprise to the people in the trenches that there was an epidemic. And we had already been here, 6 months ago, talking about the epidemic. But I do think it helps because in his announcement of that, he did break down some of the stigma. I believe he spoke for the need for more treatment services and funding. And I think that hopefully the federal funding will come out a lot more than it has so that we can provide more treatment services. With regards to regulation, I really hope that the federal government realizes what regulations are barriers to the treatment. To speak more specifically on the medication-assisted treatment, there is scientifically proven treatment for someone who is addicted to opioids. And if we can give them that treatment, then they will not divert into the criminal system and may not divert into unsafe health consequences like needles and get HIV and stuff like that. This medication-assisted treatment really comes in two forms. One is methadone clinics, and the other is buprenorphine, which is a tablet that we can give that has some of the properties of an opioid, but some different properties that allows people to function. So you take this pill, but you can go to work, you don't commit crimes, and stuff like that. Now, we can argue about methadone clinics and whatnot, but what I would stress to you is that regulation-free, just with the regular certification that I have as a doctor, I can prescribe methadone for pain. No regulation at all. I can prescribe it for pain, which has the potential of all the opioids of getting patients addicted. If I want to prescribe it for the treatment of the addiction, the red tape is tremendous. The barriers to doing that are tremendous. So no barriers to getting people addicted to it, but then a lot of barriers in trying to fight that addiction. The same is true for buprenorphine, where the DEA makes you go and get special training in order to be able to prescribe that for addiction, and then regulates how many patients you can treat and all of that. Whereas for pain, there's no extra regulation. So we can argue about whether there's the need for the regulation, but my question would be, why is there such a discrepancy on the regulation between treatment of pain and then the treatment of addiction? And why isn't there parity for those two things?
We've got to provide more authority and more latitude for medically assisted treatment, because as we get a handle on the supply of prescription drugs, as Dr. Beeman described, the tendency, unfortunately, the syndrome is that you migrate into street drugs to feed your addiction. So if we're able, in a comprehensive way, to provide medically assisted treatment, as we're getting a handle on oversupply, we're getting a solution in place. If we don't do that, we're really missing the boat. And as I've said, it's important to be smart on crime. It's important for punishment to be proportional and to be civilized. But unless you're committed to funding levels and approaching in a dual priority way the need of the state, the responsibility of the state to provide treatment options, you're not getting a handle on the problem. You're only solving half of the problem, therefore you're not solving the problem.
And so one of the initiatives that we've started at OSU is this waiver training, this extra training. And our goal is to have every doctor that graduates from OSU to have this waiver, whether they're going into pediatrics, whether they're going to OB or family medicine. And with our history and pattern of distributing doctors around the state, most of our graduates do stay in the state of Oklahoma. We think by getting an extra 100+ doctors certified per year could make a tremendous difference in the availability of medication-assisted treatment.
We have probably less than 10 minutes remaining, and I want to make sure you all have plenty of time on this one. So kind of a two-part question. What have you learned about this epidemic in the last 5 or 6 months since we met last time? What's new to you? And as part of that, what hurdles have presented themselves to dealing with the opioid epidemic that have popped up in that time frame that maybe you hadn't anticipated, and how are you dealing with those? And we can, Jessica, why don't you start?
Well, I learn a lot every day. In my job, no 2 days are the same. One thing that I think is becoming more and more solidified in my mind is that we all are sort of in this culture, not just doctors, but we're all in this culture of understanding how to treat pain, and to change that norm in your mind about needing medication, that there really are no other options that would be effective, is a difficult one, even for the patients, even for the community at large. So what I'm really understanding, and what I want others to understand, is really what we know about these medications, really how addicting they are, that they're not particularly helpful for a lot of painful conditions. I think that's really a norm change for a lot of Oklahomans and people in general, to learn that they aren't particularly great as pain medicines for many different conditions. Also, that 30% of patients who get a 30-day supply of opioids are still on them a year later. 30 days can't be our norm anymore of what a reasonable or decent prescription looks like for certain types of pain. So for me, it's really a daily culture shift in trying to help shape messages for Oklahomans, for even physicians, for patients, for others to really understand what we're dealing with. We have to reduce the incidence of new addiction. And the best way that we can do that is to really be much more cautious in our prescribing. And so really I spend a lot of my day thinking, designing, and helping and talking and partnering with people about how we do that. How do we get Oklahoma out of the top 10 for states prescribing these drugs? What sort of interventions can we put in place to make sure that patients know what they're getting, that they're fully informed? And also to make sure that those treatments are there appropriately when needed. So for me, we've talked a lot about the barriers today, funding being one, that sort of elusive ability to make a plan, a 5-year, a 10-year plan, because of the lack of sustainability of our funding. That has been a major barrier for us. And also bringing all the right people to the table. But I would say absolutely in the last year for certain, under our state's leadership, and just through the sheer impact that Oklahomans have had with this issue, being touched by so many people in their lives with this issue, we've seen so many people come to the table, and now it's solution time, where we're really trying to figure out what are those top ideas that we have to bring to the state. We've talked about many of the barriers, and I remain hopeful. I think that we're going to get out of this. We're going to be able to address this. We've already turned some of our numbers in the positive direction, and I think that we can continue to do that.
I would also just say, to piggyback off of what Jessica is saying, I think the conversation has been more open, and it's in different ways. You know, having a conversation with maybe somebody that is pro-life and talking about how medication-assisted treatment actually is part of that pro-life movement, because we're saving not only the mother but the unborn child, you know, or looking at, you know, that sometimes this might be your next door neighbor that again had their wisdom teeth out and there has now been an addiction. And so I think that the door has been blown wide open to have the conversation, and that's the thing that I keep learning, is there's always a method or a way to have the conversation. Again, I don't feel like anyone's completely shut the door and has said, I don't want to hear what you have to say on this. And so I think that's also what I'm hopeful about and excited, and hope that that keeps moving forward. But I think a big barrier is the prevention side. I think sometimes we don't know how to quantify or how to show that if I prevent something over here, you know, it doesn't ever happen. Unlike, you know, if I have 10 people that are needing treatment, I can show that I did treatment for those 10 people. And so I think a big barrier is just, again, that education piece of how important prevention really is, and getting people to understand that, yes, sometimes you don't see the individual or the number, but that we have been able to totally change people's lives in the front. And so I think as time goes on, I hope that we move towards a very strong prevention side, not only treatment, but definitely more on prevention, so we don't see this for later generations to come.
General Hunter?
Well, one of the things that I believed, which I have seen a lot of data and heard a lot of testimony and am convicted about, is that the 80-20 rule, as it's applied to prescribers, is apt. And those figures are imprecise. I'm not saying 1 out of every 5 prescribers is running a pill mill. But the ability of a very small number of people to affect a really, really significant problem is a rule. And we're seeing it in the state. There are still pill mills in the state. There are still prescribers who are overprescribing. Our office has chosen to hold those people accountable through charging them with criminal acts, and we're going to continue to do that. But I just want to underscore the cooperation, the collaboration, the commitment that the medical community has had to the Commission, and working with our office has really been encouraging, and it's a big part of what we need going forward to get a handle on this. So I'll make that point. Secondly, I don't want to point any fingers here with respect to either members of Congress or the administration, but the federal government's got to get its act together. It's one thing to provide us funding for treatment programs. That's important. We needed that money. But there's a law enforcement piece to this, and there's a stemming supply responsibility that the federal government has that I believe they have to be much more aggressive about. So fixing the problem that legislation created with the DEA, when we talk to line agents in the state, their ability to interdict activity through pill mills has been almost completely curtailed by legislation that emasculated the DEA. I've written the congressional delegation, congressional leadership, and asked that that bill be repealed. 43 other attorneys general joined with me on that. So when you still have companies doing things like putting 9 million pills into a small West Virginia town of 300 people and there being no accountability for that, when every man, woman, and child in northeastern Oklahoma received enough pills for them to have received 90 pills, every man, woman, and child would have received 90 pills based on the supply, that's unconscionable. And the supply piece is something that the federal government is uniquely positioned to get a handle on because it's interstate commerce. And so I've also written the AG about this, and I'm hopeful that there'll be a commitment to dealing with that. So where we go from here is we're going to do what we need to at the state level. We've got great partnerships, great collaborations. Our lawsuit is focused on what it needs to be focused on. So those are the things that I would share with you, Ted, with regard to what I've seen and what I've learned and what's been, I guess, validated over the last several months.
Dr. Beeman?
I would say that at OSU in the last 6 to 12 months, we've really learned that if we're going to affect change, and I'm optimistic that we can wipe out this epidemic based on all of the collaborations and partners and interested individuals. If we're going to do that, it's going to require a comprehensive approach that looks at current treatment, looks at research regarding why people get addicted, how you treat addiction, advocacy so that we can advocate for proper prescribing and also advocate for decreased stigma. And then really most importantly, as everyone has said, is prevention. And what does prevention look like from prescribing, but also through traumatic childhood experiences that causes individuals to get addicted in the first place. If we're going to do all that, it requires a comprehensive 5 and 10-year strategy. And we've put that together in the creation of a Center for Wellness and Recovery at OSU CHS that is going to be tasked with putting all these things together and fighting the epidemic in a public health kind of mandated approach. One thing that I've really been surprised at in the barrier is the response from pain management specialty in Oklahoma, that I think that there's a lot of misinformation that the Attorney General is going to arrest anybody who prescribes opioids, and I think he's been very clear that he's not doing that he's going after the physicians that are intentionally and knowingly misprescribing and feeding off of someone's vulnerable addiction, and really is just a legalized drug pusher. And those are the individuals that he's going after. But also that we don't want to give opioids to individuals in pain, that we don't want appropriate treatment of pain, and that's not the message at all, that we really do think that people need treatment for their pain. There's evidence-based scientific ways to do that, and we feel like that's what we need to do. If you follow the evidence, like instead of giving 30 days, give a 3-day supply, then your outcomes are much better. And we want to hold, as a physician myself, we want to hold other physicians accountable to their prescribing practices, and not necessarily in a bad way, but say, have you read the CDC guidelines? Have you heard of this study, and have you seen this study that have shown you don't need to do things the way you've done it before, and that you can do things safer and much better? And so that's part of our push, is to try and not only educate physicians on addiction, but educate them on the proper treatment and prescribing of pain.
Okay. Have a quick final thought from each of you. It sounds to me, if I were to summarize today's discussion versus the one we had this summer, I'm hearing a lot more about collaboration. It feels to me like we started out with everybody looking at their own piece, and here we are in December where those pieces seem to be at least starting to come together in a more cohesive approach to battling the epidemic. At least that's just my sense from listening to you. But I wondered, to start with you, Julia, just a short final thought on where we are and where we go from here.
I think where we are is really exciting because we're all starting to come to the table and again collaborate and have an open discussion, a widespread discussion. And I think if that just keeps continuing on down the path, kind of like Dr. Beeman said, that, you know, hopefully we will get a handle on this epidemic and it'll, you know, eventually go away and we won't have these issues anymore. But that would be my hope, is that we just continually have these conversations and these efforts to partner across our state and just keep moving everything forward.
General Hunter?
Well, for those who place a high value on protecting the lives of the unborn, I would just suggest that they consider this data point. We're seeing from DHS every year their numbers on substance-impacted infants. And we're seeing a steady increase. I'm sure nobody's surprised given the consequences, predictable consequences of the epidemic. But we had around 500 identified substance-impacted infants last year. We're on a course right now to have almost 1,000. So that number has doubled from 2016 to 2017. And that's absolutely unacceptable.
I just think about everyday Oklahomans and what they can be doing differently. You know, and you talk about this subject matter, it's pretty easy to walk away thinking this is all in the hands of physicians and big drug companies and other things. But for us, I want to make sure everybody knows that we hope that they are talking to their doctor and getting full information about the treatment of their pain condition. We want to make sure that people are locking up their medication and not with a quantity of opioids that are in Oklahoma, to make sure they're not getting into the wrong hands. We also want people to know that you can and should carry naloxone. It's now available to every Oklahoman without a prescription. We have about 30 community organizations throughout the state. You can walk in, ask for a kit, and get one for free and have that, whether it's a loved one that you're worried about, or your mother, grandmother, somebody who's on chronic opioid therapy and you're concerned. You can have a kit and you can have that with you, particularly in rural Oklahoma where emergency medicine may be far away. It's probably a good idea. And we also want to make sure that people are encouraged to know that our state has a pretty robust disposal system. So when you're through with medications, when they're expired, let's get them out of circulation. You can take them to a disposal site for free, no cost, and they're safely disposed. Because we do need to greatly also decrease the amount of medications that are circulating out there in the community. And I would hope that every Oklahoman would be able to do at least one of those few things to help with this problem.
And I would say that, as I said 6 months ago, that this is, as a physician, this is the epidemic of my generation. This is my HIV or my bubonic plague, and we need to treat it as such. There are public health accepted approaches, and we need to be doing that. At OSU CHS, our president and dean, Dr. Casey Schrum, has made this epidemic her #1 priority and is putting all of her efforts and resources through that, through education, research, and clinical services. And we really hope that in the next 5 to 10 years, we can make a dramatic difference.
Well, thank you, all four of you, for participating today. We appreciate your thoughtful expertise on the subject and sharing that with our audience. Certainly, we also want to thank our sponsor, Bob Howard, who has a connection to this topic. And Mercedes-Benz of Oklahoma City for helping us to make this happen. And those of you who are here in person, thank you for being here. Have a good afternoon.